All right, ladies and gentlemen, our next speaker is a visionary in the field of ophthalmology, a specialist surgeon whose dedication to advancing eye care has left an incredible mark on the landscape of refractive and cornea surgery. Dr. Lourens Coetzee is not only a brilliant mind in the world of ophthalmology, but he's also an adventurer exploring the world beyond the operating floor. Dr. Coetzee wears multiple hats with incredible finesse. As the director of the Mira Eye Clinics, he leads with a vision of exceptional eye care. His areas of special interest include cataract, cornea, and refractive surgery, where his expertise shines brightly. Dr. Coetzee's journey in ophthalmology is a testament to his unwavering commitment to learning and growth. He has attended numerous international courses, learning from esteemed experts and institutions around the world. His dedication to advancing the discipline extends to his role as a member of the Refractive Surgery Alliance and as a preceptor for the RSA Fellowship Network, where he trains the refractive surgeons of the future. He is also a stakeholder of the World College of Refractive Surgery and Visual Sciences, further showcasing his dedication to advancing his field. His passion for progress is not limited to his professional life. It extends to his research in refractive and cornea transplant surgery. Today, Dr. Coetzee will share his profound insights on a topic that concerns us all, uveitis. His expertise in ophthalmology promises to shed light on this condition and its impact on eye health. Ladies and gentlemen, please join me in giving a warm welcome to Dr. Lourens Coetzee.
Hi, Matt. Hi, everybody. So let me just share my... okay, I'm going to...
You okay there, Lourens?
Yeah, I just want to quickly share my screen here. Okay. So if you, and just give me a minute, I just want to restart my PC. So I need to, it's Apple and Microsoft. Okay, I'll see you guys now.
And just a little bit of technical difficulties. Okay, so while we wait for Dr. Coetzee, Annie did ask in the chat, it said, true to that managing the disease won't mean that pain will go away. This is an ongoing issue for each of us. And Linda responded on the question on pain threshold, yes and no. Yes, the symptoms have thresholds and can shift. People's pain thresholds have more to do with the unique mix of vulnerability and resilience factors than with the system's threshold. Hope that makes sense. Cool. Ido, could you just promote Lourens again? He's back in the room. Perfect. Okay, Lourens, all over to you.
Right, so although I'm a refractive surgeon, all of us have done started off doing ophthalmology, and we still see uveitis, even though the majority of our patients come to become spectacle independent. So there's a few things that I'm going to discuss, and so autoimmune diseases can, like, surely you know this, and some of the more esteemed experts like rheumatologists have discussed this already, but it can be systemic or it can be organ specific. And all of these autoimmune diseases affects the eye in some way or another. And which brings me to my next slide. So rheumatoid arthritis, you can interchange that with ankylosing spondylitis, SLE, and all sort of other systemic autoimmune diseases. But you can see number one there is uveitis. But it's not only uveitis. It can also give you dry eyes. Something that we see often is scleritis and episcleritis. It's this chronic, either a nodule or general red eye, but there's no inflammation inside the eye. And then at the back of the eye, we see a retinal vasculitis that is quite common in Behçet's disease. And then conjunctivitis is inflammation also of the, not of the white sclera of the eye, but of the layer around it, the conjunctiva. And then blepharitis is your eyelid infections. There can be swelling of the macula, which is the CCD, or the photo or the film layer of the eye. And then choroiditis is basically inflammation of the back of the eye. And then it can be so severe that you can get a retinal detachment. And that is normally not because there's a tear in the retina, but because there's fluid buildup from all these inflammatory markers and processes. And then the other are more organ-specific autoimmune diseases, and I'm not going to go into much detail there. So let's talk about uveitis a little bit. So now uveitis is, the uvea basically is, you find that all over the eye. You find it in the front part, which we call the anterior chamber. Then you find it in the mid layer lining the eye, and then also in the retina, which is the film layer of the eye. And so the uvea is actually responsible for or the inflammation directed towards the uvea is actually where we see uveitis. And the uvea, as I've said, it lines from the back to the front. And like the iris is part of the uvea, or the posterior aspect of the iris. And then you get this very body and like responsible for movement of the lens, which is also a part of the uvea. And then the choroid, which is the layer just behind or posterior to the retina. So uveitis symptoms, I'm surely most of you or many of you have had this multiple symptoms, and you know what like when you get a flare up of uveitis, like when to go and see your ophthalmologist. I know many patients, some may self-medicate, which I don't advise, but it happens so often, and they get so trained in this. So the first thing is you'll find that it's very light sensitive, and you'll have a red eye and pain. Not always. Sometimes it is just irritation. But if the inflammation is severe, then you get this photophobia. So as soon as you go into light, it's not just light sensitivity, it's like a dull aching pain shooting behind the eye. And in very severe cases, especially if the back part or the posterior aspect of the eye is involved, we can get floaters. And that usually then your vision is quite reduced because there's inflammation of the retina as well. And then of course you'll see the red eye. And just again, if it's only a red eye with no inflammation in the cell, in the eye, we call it cells in the AEC, then it is unlikely a uveitis. We will then rather talk about conjunctivitis, or most likely scleritis or episcleritis. So again, the onset can be sudden or gradual, and most of you will have like a sudden onset, but many patients have this low-grade inflammatory eye involvement, where there's always a low grade of inflammation, and those patients don't get this sudden like spike or sudden onset, and then the duration, sometimes it clears up by itself, but it can also be persistent, and the only way that we can put it to an end or get control of it is by using topical steroids or steroid drops, but sometimes even systemic steroids and immune modulating drugs and biologics. But that usually, if it comes to that stage, we ask our rheumatologist colleagues to help with that, because if there's inflammation in the eye, even if there's no symptoms elsewhere, it still means that the systemic condition is not controlled, and then the rest of the system should be assessed by a rheumatologist. And then there's some just another, like we say, if it's acute, it some other terms. If it's acute, it is sudden onset and it's limited duration. In autoimmune disease, it's often recurrent, and if you're very unlucky, then it's chronic, and we struggle to get it under control. So here is where we talk about the various parts in the eye and where inflammation from autoimmune disease can affect it. So on the top part, we talk about anterior uveitis, and that's what most of you will have, and the most common presentation of uveitis, and where it's only limited to the front part of the eye. These patients often still have relatively good vision. It's just extremely light sensitive, and they can have this dull aching pain and red eye. And then intermediate uveitis, that's where we start seeing the floaters. And if we see intermediate uveitis, often drops on its own is not going to do the job, and we either use periocular steroids, so that means that we give the eye an injection in the floor to get control of this. And the same with posterior uveitis and panuveitis, and those two, it's either the back part of the eye or the complete all four areas of the eye is involved. And with those two, yes, we do give injections and around the eye of steroids, but usually we need a systemic immunosuppression there. And normally we will start the patient on an oral dose of steroids, but we would then urgently ask our rheumatology colleagues to take over and put them on a steroid-sparing agent. So one must not, if one see a patient with uveitis and they've got an autoimmune disease, we should not only look or focus and just assume that it is due to an autoimmune disease, because it's quite common, and there are many other causes of uveitis as well. We've got viruses, and which is quite common, especially the chicken pox and the fever blister virus. I would say those are probably, if there's an effective cause, those are by far and the most common. And then we get the bacteria, which is not so common, but we do see TB quite a bit, and then also the parasite, the toxoplasmosis, and especially those working with animals. And then autoimmune diseases, there we see almost all of them, and there's probably more. And then there are without systemic disease. In some cases we just don't know. I must say, in majority of cases we don't know what's the cause of uveitis. but certain drugs can also cause it, and we should not look past that. And then, especially your lymphomas, some of your cancers can also present as uveitis in the eye. So here's like just a sort of a pie chart of what's the common causes of uveitis. So 72% we just don't know. We have gone through all the tests trying to determine why these patients have uveitis. So if we see a patient first with a first episode of uveitis, we won't go through all the tests. And because such a large percentage of patients, we just don't find the cause. But if they come back, then we start looking, and you can see only 27% of patients, or let's say 28% of patients, are autoimmune related. And there's like another pie chart where you can see where ankylosing spondylitis is it's quite a large percentage of that total pie, and inflammatory bowel disease like Crohn's and ulcerative colitis as well, and the rest are quite smaller percentages, like rheumatoid arthritis, which is also quite common, but they don't present so much with uveitis, more with dry eye disease. So if you attend an ophthalmologist's rooms, this is your first time, and you've got this red eye, and you are already known with a autoimmune disease, then what it will start off with, they will just do a medical history, and often this is not done by the ophthalmologist himself. He's got an ophthalmic assistant that takes all, like, the family history, smoking history, and then also when did this condition start, and what's your medication that you've been using, is it controlled, not controlled, are you did you have any previous eye surgeries? Is it the first time that it's happened? Then it comes to the eye exam, and then there's a slit lamp, which is a device where you put your chin in front of a light source, and then there's like a microscope, and we look for all these signs. And at the bottom left, that is called keratic precipitates. So we call it KPs. So if you hear the ophthalmologist say there is fine stellate KPs or granulomatous KPs, you know that he's talking about clumping of white blood cells on the inner aspect of the cornea. We call it the posterior surface of the cornea. And there's little white dots that we can see when we look through the slit lamp or through that microscope with the slit beam. And then he will tell you that he can see cells in the AC. So that is when we look in the front part of the eye, and we see all this fine little dots floating around in that anterior chamber or in that area. And then we count them, and according to how much cells we can see in a square millimeter or block, we will then grade it as grade 1, 2, 3, and 4. And then what we also look for is, we call it the beam in the fog, and that is a flare. And that's not specific cells, but you can, if there's inflammation and you shine this slit beam through that space, it will be like a light in the fog. And depending on how much fog there is, you will also grade it. And if it's very, very, very severe, then you will see this hypopyon. So this is not very common, and that looks like pus in the eye, and that you'll sometimes see yourself if you look in a mirror. But you can also see how red the eye is, so there's a little pus line pointed out by the arrow. So that we call hypopyon, and it's not necessarily infectious. So it's not necessarily an abscess in the eye. It can just be white blood cells that have collected if the inflammatory response is severe. And then Snowballs is where you'd get clumping of these little cells. And snowballs we often see at the back of the eye, not necessarily in the front of the eye. And for that, we need a little lens that we look beyond the pupil into the back space of the eye. And then if the patient is not known with an autoimmune disease, then we'll do specific blood tests for autoimmune conditions, and we normally do a FBCSR. There's also HLA-B27, and we'll do an autoimmune profile that includes rheumatoid and that ANA and rheumatoid factor. And if we find anything positive on that side, then we refer to our rheumatology colleagues. We also then do an infective workup where we look for the other infective causes. But as I've said, in 70 to 73% of cases, two-thirds we don't find any cause. So how do we treat uveitis? We'll always start with a topical steroid, which most of you probably have used Maxidex that have had uveitis. And that's the mainstay, and we will use it for a month, and then we'll start to reduce it slowly. We will not stop it immediately, otherwise this inflammation can just recur. But if you've got an autoimmune disease, it means that the disease itself is not well controlled. So we often just write a small little note to your rheumatologist asking them to, or notifying them so that if they want, they can actually increase your systemic medication. If it is only, if the only presenting sign is uveitis, and uveitis extends beyond the front chamber of the eye towards the back chamber, which is we call it the posterior uveitis, or the posterior chamber, then we will use the periocular steroids, which is basically the injection. If the inflammation is inside, especially if there's swelling of that film layer or the CCD layer of the eye, then we will give an injection inside the eye. And if the whole eye is involved, and then we will use systemic steroids like oral steroids, oral prednisone, that you will also take for 10 days, and then you will taper, and hopefully in that time you can see a rheumatologist as well. It's also important to keep the patients comfortable. So the reason for that photophobia or that light sensitivity is because the iris is quite irritated by these inflammatory cells floating around. So if we shine a light in the eye, the pupil constricts. So it means that iris, the muscles in the iris contract, and that actually can give quite significant pain. The pain can actually radiate into the back of the orbit, and we would then paralyze these muscles, which we call cycloplegics, just for the short term. And we don't only do it for pain, because we know that these inflammatory cells can actually cause like fibrosis. Everything can grow stuck together. And if this pupil is very small and pinpoint, and it grows stuck to the lens, then we can get buildup of pressure. There's so many things that we can, like issues that we can get. So that's another reason of giving cycloplegics, which basically going to dilate the pupil. And then, yes, if we just struggle and it's recurrent, and this and you've got an autoimmune disease, then again we will ask our rheumatology colleagues to use steroid-sparing drugs, immune modulators, biologics, to help us control this uveitis. And then anti-VEGF agents, that's not anti-inflammatory. It's basically just an agent that we also inject in the eye, and that just helps us to reduce the swelling at the back, but it's not going to influence the inflammation per se. It was actually developed originally as a colon cancer drug. What it basically does is it sort of dries up all the blood vessels, and then the cancer can't get nutrition and it dies. So what we use, all those dilated blood vessels at the back of the eye, and that is causing the swelling, it sort of just reduces that and then the fluid leaking from these blood vessels will then stop, and so we'll get reduction of the edema or the swelling of the macula there at the back. So prevention, you can't really prevent uveitis unless the only way of preventing it is if your autoimmune disease is under control. But if you recognize the symptoms early, and we can start early, then we can actually prevent serious complications in the long run. And then also just be aware that there's other causes of uveitis as well. So a lot of patients on autoimmune disease with like serious autoimmune diseases are on immunosuppressive therapy, so can be prone to some infections, especially the viral infections. So try and limit your exposure, and then you can get to know your ophthalmologist. He will also get to know you. We have our patients that we know they can just phone and pop in if they've got uveitis, or they know that they've got uveitis. And then even if they're far away and they can't come in like immediately, we will ask them to start their treatment, and then within a day or two come and see us. And then we can't manage it without our rheumatology colleagues. And then, of course, we can, like in general, lifestyle changes that can help us control the autoimmune diseases is also important for preventing uveitis. So this is the complications that we can have, and we really want to prevent that. And this, so by treating uveitis early, we can, we can try and prevent this. But macular edema, I've already alluded to it before. That is where you have got swelling at the back of the eye, and you get distortion and general reduction in the visual quality. Retinal scarring is very bad. That is usually permanent, and that we see, and it can cause permanent vision loss. That is with severe inflammation at the back of the eye, then affecting the retina. Glaucoma is high pressure in the eye, and that can often happen if all these cells starts blocking the outflow, and also if it's managed chronically by steroids. The steroids that we in the drops can actually also cause the pressure to go up, and then the patient goes blind because of the steroid drops that they've been using, and not because of the uveitis. So it's important. Steroids are good in the short term, but you can't be on it for life. So we have to change to a steroid-sparing drug systemically that you take orally, or there's some other steroid-sparing drops that we can mix. That's not available, but it can be mixed, like cyclosporin. And then cataracts, both also caused by the steroids as well as uveitis, and we often see this early on. And it's important, if you go for cataract surgery and you've got an autoimmune disease and you've had uveitis before, is to start the steroid drops before you go for your cataract surgery. So at least a week before you go for your cataract surgery, because we know that any surgery in the eye is going to increase the inflammatory response. So you want to have it nicely controlled before we start. And then the optic nerve can also be involved. And then retinal detachments, that's where that film layer comes loose because fluid builds up behind it and just pushes off the whole retina. And unfortunately, we do see patients, although very rare, we do see patients that present to us with permanent vision loss, and that, but usually in those cases, they didn't seek help early enough. Okay. Good. Thank you very much. Any questions?
Thank you very much, Dr. Lourens, for your invaluable insights into uveitis. Your expertise is truly appreciated. I don't see any questions in the chat at the moment, but if we do have any, I will forward them through to you. Thank you very much for your time.
Thank you, Matt.
Cheers. Have a great day.
Bye-bye.
All right, so we are going to take a well-deserved lunch break. Please go and make yourself some foods, enjoy your meal, relax, and we are going to return at 12:30. And we have a lot more engaging sessions lined up for the afternoon. We'll see you shortly. In about half an hour. I have prepared some videos for you to watch as we go through the lunch break.